Gladys Guevara, pambansang tobacco issue, almost every day in my feed. And friend ko si Ate Gladys. And I really don't know the story, but oh my gosh! Guys, mukhang parang may kamukha siya dito. Wait, ha? Kamukha niya eh. Sa gilid. Parang kayo po si Kolokoy ba yun?
Hello, good morning, good afternoon, good evening, everyone. Welcome po sa 131st 131 episode of the Stop COVID Deaths webinar series brought to you by University of the Philippines. Thank you for being part of our credible online community. And to all those who have just discovered us today, welcome po. At sana po marami po kayong matutunan, especially napaka-timely po ng ating topic for today. Sa mga balita po, a new COVID-19 Omicron Subvariant XBB 1.5 has been reported to be rapidly spreading around the world and possibly becoming the dominant strain in the United States. It's nicknamed the Kraken. Medyo nakakatakot po ang kanyang palayaw. And after a terrifying multi-tentacled mythical sea monster, yung po ang kanyang pinanggalingan. And maybe it's because someone wanted to have the variant be easily remembered compared to just random letters and numbers that are jumbled together. Anyway, ito po yung naging viral at marami na po ang nagtatanong about this XBB 1.5 na subvariant. But can naming it as such incite panic and undue fear? At more importantly, ito po bang mga bakuna na natanggap po natin, yung mga bakunang parating, bivalent vaccines, are they effective? Are the signs and symptoms any different from the previous iterations or previous variants po ng ating COVID-19? At ano po yung mga effective po na treatments at paggagamot? At ito po ba'y available at makukuha po dito sa Pilipinas? I'm Dr. Raymond Francis Sarmiento, Director of National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. Always a pleasure to be with all of you during our regular Friday. At nabanggit ko po sa ating chat po kanina, for today's webinar, hindi lang po basta-basta any regular Friday po natin. Very extra special po ito dahil today we have a special co-host, very international renowned po, pediatric cardiologist. Siya po ay magaling na manunulat din po and meron po siyang first-hand experience being let's say affected by COVID-19 and especially from the patient perspective as well as from the frontliner perspective. Please welcome to our webinar again. Siya po ang spokesperson of the Philippine General Hospital, Dr. Jonas Del Rosario. Sir Jonas.
Magandang hapon. Maraming salamat, Doc Raymond, for that introduction. Welcome to all participants here in live broadcast of Sub webinar. It's been a while, na-miss ko yung TVUP, no? We also, nakakatuwa na nandito ako ulit. And I'm sure there are a lot of people who have been following this award-winning webinar, no? Umabot na sa buong mundo. Parang COVID, no? Kumalat, no? And so, as usual, we welcome everybody who has joined us via live streaming on TVUP YouTube channel, the UP System Facebook page, meron din tayong TVUP Facebook page, the Stop COVID Deaths Facebook page, and of course, all those watching from TVUP Signal TV channel 101. For today, we have a highly esteemed panelists, including Dr. FRANCO FELIZARTA and Dr. CYNTHIA SALOMA. Okay, so as you've seen in our opening billboard, we will still maintain the title Stop COVID Deaths, but we'll expand our discussions to C, current COVID-19 problems, O, other outbreaks, V for viruses, I, infections, and D, disasters. So nag-level up, no? Stop COVID Deaths leveled up to take a closer look at other emerging health problems in the community, while we keep an eye out for other COVID-19 developments here in the Philippines and of course the rest of the world. And since we know that you like to be current with the latest news in health and medicine here and abroad, we have a new segment in the webinar called News Updates.
Thank you so much, Dr. Jonas, para sa ating kauna-unahan news update, at least for our webinar for today. There's one article that came out entitled Learning to Lie, AI Tools that are Adept at Creating Disinformation. So alam nyo na po ito, malamang narinig nyo na po ito, yung ating ChatGPT by the group from OpenAI who has developed this conversational AI po. You can give it instructions if you wanted to have it write maybe an essay or a paragraph po. Your assignment, pwede rin po kung gusto nyo po na sa wikang Shakespearean, pwede po ito, Roman, o kaya gusto nyo kung ang sasalita ay may punto po ni Morgan Freeman, pwede po yun. Anything that can be done using this conversational AI could be done, at least for those that have tested it. And what we have found, at least for this article, researchers have found that an AI is able to tell eloquent lies. Yung mga kasinungalingan po tungkol po sa COVID-19. Si ChatGPT po, ito po yung pangalan po ng AI tool, wrote an eloquent paragraph containing misinformation. Kaya po niya iyon about COVID-19 vaccines when researchers at NewsGuard asked the artificial intelligence chatbot to produce content from an anti-vaccine activist's perspective. So the researchers say ChatGPT refused to write a story. Ano lang po to, in comparison, ChatGPT refused to write a story claiming that President Obama was born in Kenya dahil hindi po ito totoo. But it complied when it was told to produce misleading paragraphs on COVID-19 and immigration, among other topics. So very important lang po that everyone is kept abreast of something such as this. So as mentioned po, it can be used for good, it can be used for something otherwise, but hopefully we'll be able to learn so much more about the ethics of using artificial intelligence. How about you, Dr. Jonas? Ano pong balita?
Well, ang balita sa akin, medyo nagulat lang din ako doon, being a pediatrician, a pediatric cardiologist at that, and of course, as a parent, no, I think this is very important to parents out there, no, a news that came out of Reuters, no. WHO right now is investigating on the deaths of more than 300 children from 3 countries who took cough syrups. What they're thinking is there might be a link in the way that the manufacturers have been formulating or putting raw materials in this cough syrups. They have not specifically named the manufacturers, but these manufacturers so far have been identified in India and Indonesia. What happened was it set alarm because more than 300 kids, as I said, they have been dying of acute kidney injury. It started in July of 2022 in Gambia, and then later followed by cases in Indonesia, and then in Uzbekistan. No? And what they are thinking of is the toxin available in cough syrup, namely the ethylene glycol or the diethylene glycol might be contaminated of some sort. No? So I think this is something that we have to keep an eye on, and I think it also set an alarm or a warning to parents, no? Mag-ingat po tayo sa mga pinapainom nating gamot, lalo na yung mga cough syrup. It's over the counter. Most of these medicines are over the counter. Hindi kailangan ng prescription. Most of the time, they're not really needed, no? So we just have to be very careful. They're not harmless at all.
Okay, thank you so much, Dr. Jonas. And that's the news for today. We'll see each other again next week for a news update. Okay, thank you so much. Tuloy-tuloy lang po tayo, no, sa ating webinar. Topic din po, as you know, descendant po ng variant XBB, ito pong 1.5. So far, sabi po ng World Health Organization, this is the most transmissible variant of the Omicron so far, although it has no evidence so far causes that it has shown that it causes a more severe disease. But to set our discussion into context, especially for those who are joining us for the very first time today, meron po tayong tinatawag na person on the street video. Ito po ay we talk to people on the street, folks on the street po, common folks on the street to gauge their knowledge so far at ano po narinig po nila tungkol po sa COVID sa kasulukuyan, especially kung narinig na po nila itong Kraken. So ang tinanong po namin sa kanila, ano po ang mga naririnig ninyo tungkol sa mga bagong variant ng COVID-19? Nagka-COVID na po ba kayo kahit bakunado na? Please watch this.
Wala akong nang ganong ka-idea about sa new variant. Pero ang sa narinig ko ay merong subvariant ang Omicron.
Ang naririnig ko sa bagong variant ng COVID-19, so definitely hindi naman ganun pa talaga kalala yung effect nito. Pero mag-ingat pa rin po tayo sa bagong variant na ito.
Ang pinakaalam ko pong huling variant ay ang Omicron variant kasi yun po yung pinakahuling lumabas na matindi or grabing variant na pinapakita po talaga sa media at sa balita.
I think maraming variants available from before and up to now. So merong Omicron, then may Delta before.
So, hindi ako aware sa mga bagong variants ng COVID-19. What I know is yung Omicron and Delta. And I think yung medyo prevalent ngayon ay yung Omicron, which is the mildest case of COVID-19.
Siguro sa strain na mas deadly yung bagong variant kumpara sa mga previous variant because mas nagme-merge yung bagong mga variant.
I think sa pagkakaalam ko, sa mga nabalitaan ko, and sa mga nabasa ko before is nagde-develop siya. I think yung Omicron nagkakaroon ng different strains.
Sa sobrang dami na pong dumadating na subvariants, nahihirapan na rin po akong ma-keep up yung mga information na dumadating sa balita.
Sa alam ko, hindi pa ako nagkaroon ng COVID after kong mabakunahan.
After ko mabakunahan ng first ko na vaccine, which is AstraZeneca, nagkaroon ako ng COVID in between my second vaccine. So bago ako magka-second vaccine, nagkaroon ako ng COVID-19.
Had the symptoms, pero hindi kasi ako nag-take ng test because of the inconvenience.
Na-experience ko nagkaroon ng symptoms like inuubo, sinisipon, and light fever.
Ko po ay okay lang naman po yun kasi yung bakuna ay pina-prevent ka lang naman po na maka-experience ng malalang symptoms, pero hindi naman po ibig sabihin na hindi ka na magkakasakit. So kailangan pa rin po nating iwasan or magkaroon tayo ng mga preventive measures kaysa magkaroon ng sa dulong pagsisisi po.
Well, with the pandemic crisis, I think tumataas naman ang vaccination rate natin, pati ang ating booster rates dito sa Pilipinas. So I think mas marami tayong nahikayat ng mga mamamayan para magpabakuna. So medyo na-lessen siguro yung ating mga COVID cases.
Kaya naman, inanyayahan at ang ating mga mamamayan na talagang patuloy pa rin na sumunod sa mga safety standard protocols ng ating pong pamahalaan.
Okay. Go ahead, Dr. Jonas, sir.
Thank you, TVUP, for letting us know what the people on the ground are thinking. No? Talagang magandang marinig natin yung mga alam ngayon ng mga tao. No? Talagang maraming buzz. Many people are saying, mild na lang tong COVID, yung Omicron ay nandyan na. But it's nice to know marami pa rin tayong hindi alam dahil maraming nagbabago.
Okay, thank you so much, Dr. Jonas, and thank you also to our TVUP teammates po, no, especially for that insightful po at least na the other one that that was interesting to me was that just because I've heard this so many times, yung po nagpabakuna siya ng AstraZeneca tapos in between saka po siya nagka-COVID, which I haven't really heard of it so much for the other vaccines, but anyway, just a little bit of housekeeping po for today. Certificates of attendance will be given to those who have watched at least 50% of the webinar duration. If you have any questions or if you feel that you should have received your certificate but did not, please let us know by emailing us at stopcoviddeaths@up.edu.ph. But before we delve into the webinar po, no, we'd like to tell you that we'll be having a standard panel discussion format. We have two speakers, excellent speakers for today po. That will be followed by our standard Q&A session wherein you'll be able to ask your questions. Maybe if kung mapili po namin sa inyo, we'll ask you to join the panel po to ask your questions live to our speakers for today. But before we delve right into the webinar proper po, no, meron po tayong cute intro video for our fun quiz segment for today.
Hello? Hello? Hello?
Kumusta na kayo lahat?
Hi, I'm Doc Trucy, the mini Doc Susie.
And I'm Doc Radar, the mini Doc Raymond. Are you ready to have fun? Simply open your browser to www.slido.com and enter your code to participate. We will discuss your answers during the panel discussion later on in the program.
We will have it flashing on your screen in a bit, and we look forward to your answers. Masaya at madali lang ito. Join na!
Iba-iba yung animation namin dito, Dr. Jonas. Dati
Ang cute nyo, para kayong mini avatar na cartoon
Saranggola
edition.
kami dati, ngayon naman Year of the Water Bunny siguro, kaya
Kaya pala.
nakalagay doon si the bunny or rabbit suit. Kaya ganun. Okay, so meron po tayong dalawang katanungan for today. Those who are watching us outside of Zoom, Facebook man or YouTube man ito, you can open up your browsers and type in slido.com, and when you are prompted, you enter the code 6510096. That's 6510096 for you to be able to participate in our fun quiz segment. So dito po sa ating fun quiz, meron po tayong dalawang katanungan. Ang una po nating katanungan dito, what is the best immunity against COVID-19? Is it A, with booster? Is it B, hybrid immunity? May bakuna ka at nagkasakit po kayo. Number 3, primary series lang ng inyong bakuna ang inyong natanggap. Or letter D, natural immunity or yung nagkasakit po kayo dahil po sa COVID-19. I'd like to take this opportunity to greet those who are joining us from the Tarlac Provincial Health Office in Tarlac, Bicol University Impolangi Campus Albay, Capiz Emmanuel Hospital Incorporated in Roa City, Capiz, Antique Medical Center in San Jose de Buena Vista, Antique, and J.R. Borja General Hospital in Cagayan de Oro, Misamis Oriental. Okay. For our question number 2, sige lang po, sali lang po kayo sa ating fun quiz segment. Question number 2, okay. What is the best treatment for the infection with Omicron Subvariant XBB 1.5? Isa lang po ang tamang sagot dito, ha. Is it A, antivirals such as molnupiravir, remdesivir, Paxlovid? Is it B, yung mga MAB, monoclonal antibodies po natin? Ito po ba yung bibigay? Binibigay pa po ba ito para sa mga nagka-COVID? Is it C, yung ating antibacterial na azithromycin? Ito po ba ang unang binibigay po natin? Or letter D, lahat po ng nabanggit na mga gamot ay epektibo or the best treatment para sa COVID-19 Omicron Subvariant XBB 1.5. So we will not be closing our fun quiz segment po dito, no? As we move straight into our webinar proper, Dr. Jonas will introduce po our very first speaker.
All right, thank you, Raymond. It is with great pride and honor I'm so happy to introduce my classmate, a proud member of the UP class of Medicine 1991, no other than Asuke, a well-known figure in the Philippines. Even though he is based in the United States, I can say that he was very much involved in our fight against COVID here in our country. He's an infectious disease specialist, very productive researcher, an UPMASA awardee for research. And he's done so many things to help us in our fight against COVID. No other than Dr. FRANCO FELIZARTA.
Thank you for the kind introduction, Dr. Jonas. Maraming salamat. So magandang hapon po sa inyo lahat. Let me share my screen. You can see this.
There we go. There we go. Yeah. Go ahead, Dr. Franco.
So good afternoon to all of you. So today we will discuss the updates on the Omicron Subvariant XBB 1.5. So parang iPhone different versions. Ano bang latest iPhone version ngayon? 14? So 14.
14 Pro Max, sir. Yes, sir.
14. So I'm confident the Omicron will catch up with that with 14. So right now it's 1.5. So these are my disclosures. As Jonas mentioned, I participated in more than 180 clinical trials with pharmaceuticals and NIH. So and mainly for HIV, hepatitis C, and COVID. Okay, so we will first discuss the XBB mutations, and then growth advantage and the effect of the Omicron Subvariant XBB 1.5 on monoclonal antibodies. And then we will take a look at the US and worldwide epidemic curves. And then later we will review the effect of the Omicron subvariant on the antivirals and vaccines. And then last, we'll review the efficacy of the bivalent vaccine. In the United States, we don't have the monovalent vaccines anymore. So all of the booster vaccines are bivalent, which is a combination of the original virus and the Omicron subvariant BA.5. So let's start. The XBB Omicron subvariant is actually the first major recombinant variant. So it's a combination of BJ1 and BA.2.75. So it's a recombinant variant. There are other recombinant variants, but this is the first major recombinant variant. So now let's take a look at the mutations now. So XBB have 8 major mutations, and these are 5 of those 8. And the addition of a mutation at position 252 will give you the XBB1, and then an additional second mutation at position 486 will give you the XBB 1.5. So you have 8 major mutations plus 2 minor mutations, and from the original Omicron subvariant, you develop XBB 1.5. So these are the United States Omicron subvariants. In October, the main variant was BA.5. Okay. In December, the dominant subvariants were BQ11 and BQ1. Okay, more than 50% of the variants. But now, this week, the most dominant variant is XBB 1.5. So it's about 49%, together with the original XBB of 3%. That's more than 50% of the variants in the United States are XBB. In the Northeast, especially this XBB 1.5 started in New York. So in Northeast, it's more than 70%. I think almost 90%. Of course, BQ1 and BQ11 in combination is about 40%. So that's the dominant virus before the XBB 1.5. So this is just a review of the major variants. This is the original one. And then this is the first major mutation, position 614. So you have the D614G mutation. And then you have Alpha, Delta, and these are the major subvariants of the Omicron variant. So you have BA1, BA2, and then BA5. And remember, in the United States, after BA5, we have BQ1 and then XBB 1.5. Okay, so this is all the Omicron subvariants. We will not, of course, we will not discuss this. Might take me 30 minutes to discuss all of this. But there's XBB 1.5 is not even here because that's one of the newest subvariant. But suffice it to say, the XBB came from BA2 and the BQ1 came from BA5. So this slide is showing that there's a correlation between the Omicron subvariant, the number of Omicron subvariant mutations, and the growth advantage. So for example, BA4 and BA5 have 3 mutations, okay? Compare it to BQ1, which has 5 mutations, and this translates to a weekly growth advantage of about 60%, okay? BQ11 has 6 mutations and has a growth advantage of 100%. XBB has 8 mutations and the growth advantage is about 200%. And we know XBB 1.5 has 2 additional but minor mutations. So definitely the growth advantage will be more than 200%. And if you compare it, for example, to measles. Measles has a basic reproduction number of 18. If we were all immunologically naive and the first variant was XBB 1.5, the basic reproduction number is probably going to be more than 20. It's just different now because we're not immunologically naive anymore. Most of the patients are vaccinated and or infected, and we'll discuss that later on. So we will discuss the effect of the Omicron subvariants on the monoclonal antibodies first, and then the effect on the antivirals, and the third one will be the effect on the vaccine. So let's look at the monoclonal antibody evasion first, okay? With regards to the evasion, these are all the monoclonal antibodies that are available. All of them will work against alpha, okay? With delta, there's some resistance, but with the Omicron, these are all the Omicron variants, subvariants. Most of the monoclonal antibodies are useless except for bebtelovimab and the combination of silgavimab and tixagevimab, which is this one, which is the brand name is Evusheld. So we've been using this last year because there's still some activity. Sotrovimab, I participated in this trial. There's some activity, but it's not really significant. Now, how about the effect of XBB on the monoclonal antibodies? So as you can see here, just looking at the XBB, which is the red, okay? There's really no activity for bebtelovimab, and the same thing with Evusheld, no activity. It's useless. So all the monoclonal antibodies are useless against the XBB variant. Maybe except for sotrovimab, there's some activity here, but this is not clinically significant. So in summary, all the monoclonal activities had no activity against XBB. It's not going to work. How about for XBB 1.5? Essentially the same. It's the same as XBB 1. Evusheld and bebtelovimab have no activity. There's some activity for sotrovimab, but this is not clinically significant. So this is the WHO risk assessment for XBB 1.5 Omicron subvariant. So we already talked about the growth advantage, the antibody escape with regards to monoclonal antibodies. And how about severity? There's really no clear data, but XBB 1.5 does not carry any mutation that's known to be associated with potential change in severity. So, and if we look at the epidemic curves, I'll show it later, there's really not much increase in deaths. So we don't think that there will be an increase in severity with XBB 1.5. So the overall risk assessment, XBB 1.5 may contribute to increase in case incidence globally. However, the assessment, the confidence in the assessment is low because the growth advantage only estimates were only from one country, which is the United States of America. So there's actually a significant chance that the Philippines will not get XBB 1.5. Especially you already had XBB and then it disappeared, and XBB, I thought, from XBB you'll have a XBB 1.5, and we don't even have any XBB 1.5 in the Philippines. And this will be discussed later by Dr. CYNTHIA. What about the effects on the antivirals? So we have three antivirals: the molnupiravir, the nirmatrelvir combination with ritonavir, and remdesivir. So let's start with the major variants first. GS44154 is remdesivir, and EIDD1931 is molnupiravir. And as you can see, there is no loss of inhibitory activity across all variants. So all the antivirals will work for the major variants. How about XBB? So as you can see here, there's no loss of inhibitory activity. So all the inhibitory activity of all these antivirals, including nirmatrelvir, are retained. If you look at the IC50, the activity is actually even better for XBB compared to the ancestral 1.4 versus 1.8 for remdesivir. And the same thing for molnupiravir. It's better for XBB than the ancestral for molnupiravir. So if anything, it's actually better, at least numerically, for the antivirals against XBB and most likely against XBB1 and XBB 1.5, because they're essentially the same. So we already discussed the effect on the monoclonal antibodies. It became useless, but the antivirals were not affected. And how about the effect on the vaccine? So this one is a study after 3 doses of Coronavac, which is Sinovac. So that's a primary series plus a booster. And as you can see here, the neutralizing antibody is 20, which is low compared to the original Omicron variants, and much lower than the original virus with the D614G mutation. So much lower, okay? This is Coronavac, 3 doses with subsequent BA.5 infection. So this is a hybrid immunity. But even with the hybrid immunity, it's only slightly higher, 26 to 27. Before that was 20 to 20, and still much lower than the original virus with the D614G mutation. So it's affecting it substantially, the Omicron subvariants, the neutralizing activity of the vaccines. How about XBB 1.5? So previous to that was XBB 0.1 and XBB, we discussed that. So now we're gonna talk about XBB 1.5. And as you can see here, there's really not much difference between the two. 22 versus 25, 25 versus 27, 30 versus 35. These are all Coronavac virus, Coronavac 3 doses followed by different kind of infections, Omicron subvariants. Now, mRNA vaccination, which is either Pfizer or Moderna, the neutralizing antibody is just slightly higher, which is 56 to 70, just slightly higher compared to the Coronavac. And this is also a hybrid. All of these are hybrid immunities. Now, despite the substantial antibody evasion or immune escape of all the Omicron subvariants, including the XBB 1.5, there's actually only slight increases in deaths, in daily deaths. This is the worldwide epidemic curve, okay? Only slight increases, much lower than Alpha, Delta, and the original Omicron variant. Much lower. And this is also despite of the increasing worldwide activity. So at least here in the United States, there's no more social distancing and minimal masking. Okay, we only use masks in the hospital and in the clinics. That's it. Outside, there's no masking and there's no social distancing. So despite the substantial antibody evasion of Omicron subvariants, and despite the increase in activity and minimal masking, there's actually a decrease in deaths overall. This is the United States epidemic curve, and let's look at the deaths. This is the original virus, this is Alpha, this is Delta, and this is the original Omicron. And these are the subvariants. So this small one here is the BQ1, and this one is the XBB 1.5. Slight increases. It's actually decreasing now. It's already peaked, and the hospitalization is decreasing. So slight increase, but overall, the trend is clearly decreasing. The deaths are clearly decreasing. And I have to mention it again, this is despite the substantial immune escape of the Omicron subvariant and despite the increasing activities worldwide. So what is the explanation for this? Well, The clue is from the nickname Kraken. Sorry. So Kraken is actually from the Norse mythology. But this reminds me of the movie Clash of the Titans. I don't know if you remember Clash of the Titans. Liam Neeson is there, my favorite action actor. He's from the Taken, Liam Neeson, and Liam Neeson was Zeus, in the Greek mythology is the #1 god. Zeus, Liam Neeson was Zeus, and he said, "Release the Kraken." So he released the Kraken to punish the humans. And of course, in the movie, there's always a hero, and the hero is Perseus. So Perseus and Zeus are in Greek mythology. I'm not sure why in the movie they mix Norse and Greek mythology, because the Kraken is Norse mythology. Anyway, they released this giant sea serpent, which is similar to Kraken, and it's they call it Kraken, and it was defeated by Perseus. So who is Perseus? Perseus is the son of Zeus, and the mother is human. So Perseus is a hybrid of a god and human. So that's the answer: hybrid immunity. So at least 70% of the worldwide population already vaccinated, at least 75%, and at least 95% are infected. Most of these people are asymptomatic or with mild symptoms, and since they're asymptomatic or mild, they don't even test themselves, or even if they test themselves with an antigen, they don't even report it. And the antigen testing, it's usually about only 60% sensitive, and if you do it too early, it will be almost it's less than 50% sensitive. So my point here is almost all the people who are vaccinated, so about 70%, will be infected, and they will have hybrid immunity. So almost 70% of the worldwide population have hybrid immunity. So let's look at the study on the protection versus Omicron conferred by previous infection or hybrid immunity compared to immune-naive individuals. So this is a meta-analysis of all the studies comparing previous infection and hybrid immunity. So here you have previous infection, hybrid immunity with just primary series vaccine, and then hybrid immunity with booster. Okay. So this is the protections against hospital admission or severe disease. Okay. And this is the protection against any infection. Okay. So let's discuss the previous infection first. As you can see here, before 3 months, about 75% protection against any infection here, okay? At 6 months, it becomes 50% here. And at 1 year, it becomes 25%. So definitely there's waning of the protection against any infection. Now for hybrid immunity, it's just slightly better. And for that's primary series and booster, slightly better than previous immunity. But let's look at the protection against hospital admission or severe disease. So for previous infection, it's about 75% protection. There's a slight decrease with time. So even at 1 year, it's still 75%. Okay, slight decrease. But look at hybrid immunity protection against severe disease. At 1 year, here, it's still almost 100%, almost 100% protection against severe disease. There's no decrease, there's no waning of the protection against severe disease. This is even after 1 year. So what is the explanation for this? How come you have this waning protection against any infection, but you have good protection even after 1 year with against severe disease? So there's two explanations. One is the antibody levels decrease with time, okay? The second explanation is the short incubation period. The incubation period of COVID is about 3 days, and this is similar to influenza. Influenza, the incubation period is 2 days. It is very difficult to prevent infection against respiratory diseases with short incubation period, especially if it's less than 5 days. Why? Because the memory B cells these are the one that makes the antibodies, are activated after 5 days. So what happens is, because of the short incubation period, you're going to get infection first, and then it's going to be activated. You're going to have more antibodies controlling the infection, preventing the severe disease. So that's the explanation for the difference in protection against any infection and protection against severe disease. So for respiratory diseases with short incubation period, our goal really is to prevent severe disease. It's the same thing with influenza. Influenza, their protection against infection is only about 50%. Sometimes it's 30% if it doesn't match, if the variant doesn't match. But it has good protection against severe disease. The same thing with COVID. Okay, so this one is the same thing, but they're including vaccination only. So as you can see here, for any infection, previous infection is this green line, is actually superior to primary series with a booster. Actually superior. But hybrid immunity is slightly better. Okay, but this is for any infection, but for hospital admission and severe disease, previous infection is equivalent to vaccination with booster. And hybrid immunity is superior. Okay. Now, remember, this is the average of all the vaccines. All vaccines are different. So, for example, the Sinovac is inferior compared to the mRNAs like Pfizer and Moderna. And as you can see here, at BNT162b2 is Pfizer and mRNA 1273 is Moderna. As you can see here, a booster, 3 doses vaccines as a primary series with booster is equivalent to previous infection. Okay, here previous infection was superior to booster. It's because this is the average. But if you only look at the mRNA vaccines, they're the same. And for at least for Pfizer, the booster is better than previous infection. And of course, if you have hybrid immunity, it doesn't matter if it's 2 doses or 3 doses, you have almost 100% protection against severe disease, okay, with hybrid immunity. Okay, so there's also a difference between the protection from previous infections due to different variants. So for example, the risk of a BA.5 infection, this is the Omicron subvariant, is about 50% with the if you were infected previously with the original virus. If you were infected with the Alpha, you have 55% protection. Delta, 60%, and BA.1, BA.2, this is the original Omicron. If you had the original Omicron infection, and then what is your protection against BA.5? 75%. This makes sense because BA.1, BA.2 is more similar to BA.5 than the original virus compared to BA.5. So that just makes sense, okay? The more similar the virus, the higher the protection rate. Okay, so the last slides, the last 4 slides will be on the bivalent vaccine. Okay, so we don't have monovalent boosters in the United States anymore. We have the bivalent vaccine, which is a combination of the original vaccine and the BA.4 or BA.5. So they combine both in one vaccine. So, but before I discuss that, let's just review the correlates of protection for COVID-19. So this one is showing you the vaccine efficacy according to neutralizing antibody titer. Okay. So ensemble is Janssen, Cove is Moderna. So this is Moderna. And Prevent is Novavax, Cove 002 and D122 is AstraZeneca. Okay. So here it's showing that if you have 100 international units of the neutralizing antibody titer, this is pseudovirus, okay? This is not live virus. I'll explain the difference later. So for pseudovirus neutralizing antibody, if you have 100, okay, 100, the protection rate is about 90%, at least for 3 of the studies. If you have 10, okay, 10, the protection is about 80%, at least with the Moderna, 80%. So 10 to 100, 80 to 90% protection rate. So that's the correlates of protection. Now, this is the pseudovirus. For the live virus, if you use the live virus, you have to multiply it by 10. So instead of 10 to 100, it will be 100 to 1,000. Okay. The second study, this one is an older study, it's showing that the threshold of protection against severe disease is much lower compared to the correlative protection against symptomatic infection. So that's 3% versus 20%. So it means it's 6 to 7 times lower. The threshold of protection for severe disease is 6 to 7 times lower compared to the correlative protection versus symptomatic infections. So it means this one, if you want the percentage reduction in severe COVID disease, this will probably be about 1.5. You have to divide it by 6.7, and this will be about 15. So instead of 10 to 100, it's much lower, 1.5 to 15. And if you're gonna look at the live virus, it will be 50. You have to multiply it by 10. This becomes 150. So if you're gonna use a live virus neutralization assay, 15 will protect 80% of severe disease, 150, 90% for severe disease. So remember that. So because now we're gonna discuss the difference between the bivalent and the monovalent boosters. So this one are patients without previous infection, and this one are hybrid infections. So this is the original virus. This is the XBB 1, okay, original XBB 1. The green bars are the bivalent, so two kinds of virus, the original plus the BA5, and this is the monovalent. This is the original vaccine. And as you can see here, there's a decrease in the neutralization activity with different subvariants. And if you look at the bivalent booster, from 12, it increased to 55. And for the monovalent, from 13, it increased to 17. Okay, so it's about 3 to 4 times higher for the bivalent. In terms of increase, it's 3 to 4 times higher for bivalent compared to monovalent. Okay, so yeah, definitely better. Probably not much better, but definitely better. Now, remember the 15? So even with the monovalent, after monovalent booster, the neutralizing antibody, this is live virus now, is 17. So it means you still have protection for about at least 80% for severe infection. So even with this low neutralizing antibody, you still have good protection against severe disease. This is for hybrid immunity. So as you can see, the neutralization numbers are much higher compared to patients without previous infection. And here, so from 27 became 131, from 55 became 98, and it's 2 to 3 times higher for the bivalent. And this 131 is almost near the cutoff of 150, which is protection against severe disease in about 90%. Okay, so if you have hybrid, the protection is even higher, even with the XBB subvariant using only monovalent vaccine. Now, these are in vitro studies. So let's, just before going to the real world effectiveness, this is just the CD4 and CD8 responses. Remember, the CD4, CD8 are the cellular immunity. This is important in preventing severe disease also. And as you can see here, there's really not much increase in the activity for CD4 and CD8. monovalent versus bivalent is the same for cellular immunity. So this is probably because of we call it original antigenic sin or imprinting. This is more of a antigen interference, meaning the immunity from the original virus is interfering with the immunity with the new subvariants. So you can actually decrease it by decreasing the duration of the booster. So instead of boosting 1 to 3 months, the recommendation now is do the booster 6 months after the last booster or infection, because the infection is almost equivalent to a booster. So at least 6 months to decrease the interference. In the United States, they're actually pushing for an annual vaccination, just like influenza, because we think the Omicron subvariant will become seasonal, meaning just like on other coronaviruses. The common cold coronaviruses are seasonal in the United States. It starts in December and ends in March. So you can time it very well, because it's like influenza. Influenza, in terms of just effectivity against infection, it only lasts for about 3 to 4 months. So you have to time it well. You have to give it October, November, so it covers up to February or March. So it's gonna be the same for COVID-19 if it becomes seasonal, and we think it's gonna be seasonal. Okay, so this is the real world effectiveness now of monovalent versus bivalent versus severe Omicron infection. Okay, so as you can see here, the vaccine effectiveness against hospitalization or death is about 25% for the monovalent booster and about 62% for bivalent booster. So it's at least 2 times better than the monovalent. So definitely better. Not much better because this is just 62%. So in summary, even with the monovalent, there's still some additional benefit for severe infection, but definitely the bivalent booster is better. And this is, it doesn't matter if the patient is younger or older, although the difference, there's a bigger difference when the patient is older, 41 versus 35%. And there's no difference between Moderna and Pfizer. So based on this, I recommend the bivalent vaccine, definitely for the elderly, of course, for immunosuppressed and those with comorbidities, but it should also benefit adults more than or equal to 18 years old. So especially, middle age, the children and teenagers probably will need more boosters, and then the young adults is quite controversial. But definitely, anyone more than 65 years old needs a booster, preferably bivalent if you have bivalent. But even a monovalent booster would suffice. But remember, we're pushing for annual vaccination now, just like influenza. So we're hoping they're gonna update the vaccine every year, just like influenza. That should be it. Thank you.
Thank you so much, Dr. Franco. Dr. Franco, just to be clear, you're not naman recommending people to go seeking that they get sick with COVID-19, no? Kasi baka it may be misinterpreted naman na that they choose to get COVID as part of your talk, sir. Yes.
So yeah, if you know that you have let's say, of course, the highest risk are for patient who's unvaccinated and never infected. Okay, never infected, but of course you won't know that, because a lot of these infections will be asymptomatic. So that's the highest risk. And then of course and of course, if you get infected, then take advantage of it by vaccinating yourself. Then you get hybrid immunity. So even if you get infected, get vaccinated, so you'll have hybrid immunity. But just statistically, most of the individuals, most people in the world will have been infected by now. In China, just this wave in China, 80% were infected. 80% of the population were infected. Wow. So before, because of the lockdown, because we're so good in locking down, we're preventing the increase in infection rate. So before, the major variants will only infect 5 to 10% of the population, just like influenza. Influenza will only infect about 10% of the population. But now, since there's no social distancing, there's minimal masking, it's easy to infect everybody. So remember, it's very difficult to prevent infection in a respiratory disease with a short incubation period, even with a vaccination, or even with, even if you were infected before, you're still going to be reinfected, but the protection against severe disease will be much higher.
I think that's a very important point. That's a very important point. Kasi many people are saying, oh, nagpabakuna ako, nagkakasakit pa rin ako. But the truth of the matter, it's really a mild infection now. So you don't really, in PGH, we seldom really admit any patient because of COVID. The ones that we see are incidental COVIDs.
And actually, those who were vaccinated and infected with mild infection have hybrid immunity now.
Exactly.
Yes, correct.
Statistically, almost all the people who are vaccinated have a hybrid immunity. Statistically, most of them were infected, and some of them don't even know that they were infected. Now, for 65 and above, or those who are immunocompromised, or those with multiple comorbidities, at about 5% of those, and we don't know who's going to be 5%, the level will not be enough, even with vaccination. Those are the people who needs boosting. That is, for me, mandatory. Needs boosting, because you don't know if the correlated protection will be enough for them. There's about 5%, and it's totally random. You don't know which is which. It's of course, if you test them, if you have a reliable test, and it's very high, the neutralization activity is very high, sure, you don't have to boost right away.
That's correct. Okay, thank you so
Maybe
much, Dr.
Maya
Franco.
ulit sa Q&A, maybe we can ask a few more questions from the audience.
That's true. Thank you, Dr. Jonas. I have to apologize because I miss greeting those who have registered internationally. I should have been able to greet them earlier. Those that are joining us from the Chonin Hospital in Taipei, Taiwan, from Penang, Malaysia, from Bangkok, Thailand, Dammam, Saudi Arabia, and University of Fail in Saudi Arabia, Lunichi Ali University of Blida 2 in Algeria, Stockton, California, Edison, New Jersey, and Tunbridge Wells in England. So marami po ang nanonood sa atin internationally. Maraming salamat po. Thank you again to Dr. Franco, and we hope you'll be able to answer more questions during the Q&A. Next up is a very familiar face naman po to our webinar series, project leader behind the establishment of the DNA sequencing core facility of the Philippine Genome Center. And she's one of the pioneers of the executive committee, also spearheaded the establishment of the Philippine Genome Center in UP Visayas as well as in UP Mindanao. Please welcome again to your screens, Dr. CYNTHIA Saloma. Prof. CYNTHIA.
Good afternoon for everyone and to all our listeners from all over the world. Magandang umaga, magandang hapon, at magandang gabi po sa ating lahat.
Please go ahead and share your screen, ma'am.
Okay, so I'm going to share my screen now. Let me see.
Okay, there you go. Okay.
Okay, can you see it? Okay, so
Yes,
this
po, yes, po.
afternoon also, thank you very much, Dr. FELIZARTA, for the excellent walkthrough about XBB in the US and, of course, the effect of vaccination and so on and so forth. So at the outset, I would like to tell everybody that for now, we haven't detected XBB 1.5 yet in the Philippines. But I would like to take this opportunity to introduce to our audience where we are now, what are the circulating variants in the country, and what has been happening in our genomic biosurveillance effort. So as of January 26, so that's 2 days ago, the Philippines has recorded about 4,072,488 cases of SARS-CoV-2 with 65,735 lives lost to the disease. For the Philippine Genome Center, we began our genomic biosurveillance effort in January 2021, just in the beginning of the Alpha variant. And we have been reporting weekly with the help of in partnership with the Department of Health Epidemiology Bureau and the different COVID RT-PCR labs around the country. So for today, I will focus my report on the last quarter of 2022 and of course touch on the XBB variants in the Philippines. So if you look at the preliminary counts based on the classified variants here shown on the board, we have observed a substantial proportion of detected hybrid variants since September 2022. If you look at the plot here on the left, it shows the absolute number of SARS-CoV-2 variants from March up to the September 2022, overlaid with a graph of the locally detected COVID-19 cases in the country. So if you look very closely in the initial year of the wave of COVID-19 in 2022, that was characterized by the emergence of the Omicron variant as the dominant variant in the Philippines. So in the Philippines, in contrast to other countries which had a lot of BA.1, in the Philippines, we actually jumped direct to BA.2, and it's really BA.2.3, which occupied about 95% of our sequence cases in January of 2021. However, if you look at the cases, the cases really went down from March to June, despite the fact that these were characterized by months of increased activity due to the elections or the local elections in the Philippines last May 2022. And then we see a slight increase of cases in July and August, and this correlated with the detection of the BA.5 variant. Interestingly, we were able to observe a substantial number of hybrid variants, particularly the Omicron XBB-like and the Delta Omicron XBC-like recombinant lineages in the last quarter of 2022. So this is a graph that was also shared to you by Dr. FRANCO. This is an explanation of the term convergent evolution. So what do we mean by convergent evolution? This means that independent evolution of similar features, in this case, similar locations of mutation sites, where the viruses acquire these mutations, even if they are geographically distant, and that reflects to us the similarities in the coping mechanisms or the solutions that the virus finds in order to evade the immunity as well as the environmental challenges in the places where they are in. Here from the graphics of the WHO from Dr. Otieno, we can see that how the hybrid variant came about, and that was already touched a while ago by Dr. FRANCO, where we have here a combination of BA.2.10 and BA.2.75. These created this BJ.1, which actually acquired additional mutations, and now we have this XBB variant with several number of mutations that confers it immune evasive capability. And I would like to proceed now to the cases. So this has been said to be the most antibody evasive SARS-CoV-2 strain tested. So what happens is really, really interesting is every time there's something new, it's the most evasive and so on and so forth. But now as we speak, the most evasive is the XBB hybrid variant. So here we have several spike genetic mutations, and the XBB 1.5 is XBB with the additional mutation in the spike protein at the position F486P. So this is a characteristic or the hallmark feature of XBB 1.5, but so far there seems to be no mutation in XBB that increases its severity of infection. And by the way, it was first detected, take note, this is August 13, 2022. So let's look at now the local cases in the Philippines. So I have listed this as the most recent data we have of the number of cases we have detected so far from the 3 sites of the Philippine Genome Center here in Diliman, in Visayas, as well as in Mindanao. So far we have detected about 800 plus XBB variants. And then of course, XBB.1, XBB 1.1, XBB.2, 0.3 as well as 0.5. But as of 2 days ago, we have not yet detected this XBB 1.5, which probably is the dominant variant in New York and in other places in the US as well as in Europe. So if you look very closely, this is a phylogenetic tree of the data we have at the Philippine Genome Center, where it shows to you the XBB 0.2 XBB variants that we have sequenced, XBB 0.1 and 1.1, as well as XBB 0.3 and XBB 0.2. If you look very closely and associate this with the regions upon which these were detected, you will notice that a lot of our XBB variants were really detected by our facility there in the Visayas at UPMASA. So we have PGC Visayas. And of course, during the time or towards the latter part of 2022, they did a lot of sequencing, and we can, of course, assume that there is an over sampling as far as Western Visayas is concerned, but also provided us the opportunity to detect these XBB variants early on towards September, October of 2022. However, towards January, late December to early January, the XBB detection in the Visayas has already gone down, and now we have another variant, XBB, now not a hybrid variant, but BA.2.3.20, which now is the 50-50 between XBB in the Visayas. And we saw, for example, XBB spreading slightly in other regions in Western Visayas as well as in Central Visayas, but it's now declining. So look at this one. So this is a graph, or this is a phylodynamic tree. On the x-axis would be the months of detection or months of collection. And then here you have your Omicron, the traditional Omicron and variants and subvariants, and then the hybrid variants. So how many hybrid variants do we have? So far we know of XBJ, which is XBJ is an Omicron recombinant of BA.2.3.20 plus BA.5.2. So BA.5.2 is actually the dominant variant that we detected in June, July, August of last year. So we have here XBG, which is a hybrid variant. Of course, your XBB, which is another hybrid variant of Omicron and Omicron. But interestingly, we also have detected another hybrid variant, which is a hybrid of Delta as well as Omicron. And we found a lot of these cases in Mindanao. However, in the National Capital Region, we noticed that rather than these hybrid variants, we have more BA.2.3-like lineages, which are predominant in Luzon in the last quarter of 2022. So take note, everyone, that this BA.2.3 was the predominant variant in January and is associated with this very steep rise in cases in early January of 2022. So this 2.3 has acquired additional mutations and has given rise to BA.2.3.20, as well as other sublineages within the BA.2.3.20. So all of these 0.2, 0.3, 0.4, these are all children of 0.2, 0.3, 0.20, which is a child of BA.2.3. So you can see that you will notice that the Omicron variants are accumulating mutations as they go from patient to patient. So these are some of the samples that we have. And you'll notice that when in contrast, for example, to Mindanao, where we have these hybrid variants, which was predominant towards the last quarter of 2022, and in the Visayas, we have XBB. In northern Luzon, as well as in the central and Calabarzon areas, it's rather the BA.2.3 as well as the BA.2.20 and its sublineages, which became the predominant subvariants of Omicron towards the end of 2022. And we are also now looking at BA.2.3 to be also the one replacing the XBB in Western Visayas. So in terms of global distribution, I'll just go through these slides very fast. We noticed, for example, that in Asia, the predominant is BA.2.75 and BA.5.2, as well as its sublineages BF.5. Of course, we now have BF.7 in China. You have BQ.1.1, which is also detected in the US, and the hybrid variant XBB. Whereas in Oceania, the predominant is 2.75 CH1.1, and of course this Delta Omicron variant XBC.3.1. Now let's look at the other countries in North America. Now it's now 1.5, and then in South America, we have several BQ.1, 1.6. So what am I driving at? So while of course in the US, the predominant variant has been XBB.1.5 as well as BQ.1.1. We notice that depending on the continent around the world, there seems to be some predominant variants that are associated with that particular locality. And this is also true for Europe as well as for Africa. So this is our latest data and a summary for what we have been doing and the sequencing results of the Philippine Genome Center. So this is the GSAID data, worldwide GSAID data as current as of the early January 2023. Now this is the Philippine data current as of December 28, 2022. And you can see that we have an increasing number of XBB. CM.1 is like a child of 2.3.20. So these are all children of BA2.3. And then of course you have XBB.1. So you can see, for example, that we have a lot of samples collected with XBB. And I think it is also a reflection of the fact that we really had a lot of sequencing runs and samples coming from Western Science, where we found all of peak cases of XBB towards the last quarter of 2022. So this is the global heat map of the major lineages around the world. And that's why I'm sharing this to you, because this is our assignment as far as the Department of Health is concerned and the Philippine government. We keep on watching for all these other variants. And so far, these have not yet been detected, even if, of course, there are some variants under monitoring around the world. They have been flagged in other countries. We have detected earlier BF.7, and these are from travelers to China or coming from China. But so far, they have not done any, they have not done any traction. And for the Philippines, still, we have BA.2.3.20 and its sublineages with a starting point CM.1, 0.2, 0.3.4. And that is like a history of the fact that evolution of the BA.2.3, which was really predominant Omicron variant in the Philippines in the beginning of 2022. So what's next? Just to summarize, the new variants may bring about waves of infection depending on their acquired mutations, as well as antigenic profiles. And based on geographic location, particular variants predominate, acquiring additional mutations. There seems to be no evidence of a shift in disease severity from any of the known Omicron subvariants to date, and vaccination as well as prior infection continue to provide protection against hospitalization and severe disease, as very, very well eloquently illustrated by the primary papers that were presented to us and shared to us by Dr. FRANCO. And through our national genomic biosurveillance effort, we continue to track and investigate emerging variants that come into our country. So with that, I would like to thank you for listening, and you can ask your questions in a short while. Thank you very much.
Thank you so much, Ma'am Cynthia. Buti naman, wala naman papalubang Kraken at least dito po sa Pilipinas. But obviously, we keep track of the others and hopefully we'll be able to get prepared naman po and looking forward to the bivalent vaccines as well. Okay. Anything to add, Dr. Jonas?
Well, I was about to say na buti na lang wala pa si Kraken dito. All we have are mga cracking na chicharon siguro.
Sige po. Thank you, Sir Jonas. Sige po, before we proceed with the Q&A session, we'll just take a very quick break for our special public service announcement today.
Haloy, bilisan mo! Dali!
Wala.
Ha? Ano nangyari? Ba't hindi kita makapitan?
Handa ka na ba, Kaloy?
Oo naman, ate! Nabakunahan na kami. May powers na kami laban sa inyo.
At hindi nyo na kami basta-bastang makakapitan. Yay!
Sisiw!
Kaya mga bata, magpapakuna na kayo.
Stay safe and stay well. Mga bata, magpasama na sa Bakuna Center. Thank you so much, TVUP. The COVID Communication Public Service Announcement is one of the many creative outputs of the Stop COVID Deaths team to push for pediatric vaccination for children age 5 and up. We hope you'll be able to share this video clip in all of your social media accounts. Stay safe and stay well. Magpasama na po sa Bakuna Center. Okay.
So
Would you like
I guess so. This
to-
is this is a good time now to open our floor for the Q&A. No, I am sure that we have a lot of questions from the audience. So we can start the ball rolling. Sino ba unang magtatanong?
Sige. Ako na muna. I'll ask the first question, Dr. Jonas, and this comes from
Sige.
here in our Q&A. I'll ask Dr. Franco from Dr. Camilo Nogoy. What are the chances of this XBB variant causing long COVID? Does it, and I'll supplement it with a question with regards to ito po ba, if you have XBB 1.5, does it give you maybe a higher chance of contracting long COVID, Dr. Franco?
Well, long COVID, depends on also on, it can happen in mild infections too, but there's some correlation with severity, the initial severity. So the fact that most people are vaccinated and or infected, so they have hybrid immunity, decreases the chance of long COVID. Yeah, so it really depends on several factors. But let's say the first dominant virus was XBB 1.5, we would be in trouble. If it was the first variant, then of course, if everybody is immunologically naive, of course it's going to cause a lot of severe infections plus long COVID. But now, since most of the individuals are vaccinated and or infected, most of them have hybrid immunity, this decreases the chance of long COVID.
All right. Thank you for that.
Dr. Jonas?
Yes, our next question is coming from Dr. Joselito Gapas. Oh, kilala ko si Dr. Lito Gapas, Brad. The question is for Dr. Saloma. The genomic sequencing capacity of the Philippines remains limited, therefore limiting our capacity to monitor variants and subvariants. What are the strategies that are being planned or are being done now to expand our capacity, ma'am?
Okay, so I'd like to tell Dr. Gapas that actually we've expanded our capacity. We're sequencing more than other countries, even with the low cases. So here in Diliman, we can sequence 750 to 1,500 a day per week. And then, of course, we have sequencing capacity in the Visayas as well as in Mindanao, 350 a week. No, so 350 to 350. But we do not maximize that capacity because the cases are really low. But to answer that question, the Philippines now is on the verge of creating a genomics biosurveillance consortium. So a lot of the other hospitals are being trained for next generation sequencing, so that post-COVID we will be on the lookout for for emerging pathogens. So that is our and this is with the help of the WHO and of course under the sponsorship of the DOH.
Okay, thank you, Professor Cynthia. This one from Gerald Piñon for Dr. Franco. With the Kraken variant around, what are the main characteristics of this variant that we can share to our loved ones, but to our colleagues? Given the data that you presented, what advice can we best share to avoid misinformation, disinformation?
Well, in terms of infectiousness, it's the most infectious to date. But in terms of severity, it's not more severe than the other variants. It made the monoclonal antibodies useless, of course, but all the antivirals, including molnupiravir, will still work. It actually has a better activity against XBB 1.5. And of course, it affected the vaccine, but most of the individuals already have hybrid immunity. And if you are 65, elderly, 60 and above, immunocompromised or have multiple comorbidities, it's still better to get a booster because you'll never know if you have the right level of immunity against COVID-19.
Okay. I have a question naman for Dr. Saloma. Ma'am, just as a routine, no? How often do you check? Do you do genomic surveillance, especially if the numbers are low? How do you select which samples to test? Ano ba yan? Dependent sa pinapadala sa inyo o meron po kayo talagang protocol?
Si DOH Epidemiology Bureau in consultation with WHO and our friends from the Doherty Institute in Australia, they actually advise the DOH on the sampling strategy per region so that we can catch all these samples. So there is an algorithm for region to send samples to us. Kaso nga lang po, Dr. Jonas, may ibang mga regions, hindi po masyadong malimit lang sila magpadala. So for example, we are undersampled in terms of samples coming from BARM, for example, as well as Eastern Visayas, mga ganon. Pero every week po nagpapadala sila, and they are all approved. The list is approved by the DOH Epidemiology Bureau before we sequence those samples.
Okay. So wala pa po talaga nakakalusot na Kraken?
So far, wala pa. Pero it's only a matter of time that probably all these things will happen. But so far, what we have noticed is they did not really have some traction, even the others, the other subvariants.
Right. I don't know if any of our panelists can answer this. There was a question coming from Joseph Tortona. When will the bivalent vaccines be made available for the senior citizens or for the Filipinos? Wala pa di ba? I mean, meron po ba kayong alam, Dr. Saloma?
May narinig po ba kayo, Dr. Saloma, about procurement or kung...
Oo, ang narinig ko lang po yung nasa newspaper na challenges in procurement. Yun lang po yung nabasa ko.
I see. I was about to ask, I think in connection to that, so the boosters that we have are not the bivalent ones, and I just wanted to ask again, Dr. Franco, how effective are they, at least now that there are other subvariants? Can you still get these booster vaccines if they're not bivalent ones? Would you recommend?
Yes. Especially if you're elderly, immunocompromised, and you have multiple comorbidities. I showed the data that there's still an additional benefit. So 25% protection, additional benefit for these patients. So I would, if they're not expired, and let's say the last booster or last infection was more than 6 months ago, I would use the monovalent booster.
All right. We have one here, Raymond, from Dr. Dante Morales.
Yes, go ahead, Dr. Franco.
Yeah, for Franco ulit, classmate. Please comment on the Lancet reported study on the lack of effectiveness of molnupiravir compared to the original study reported in New England Journal of Medicine. Do you still recommend molnupiravir in symptomatic mild cases? Thank you.
Well, the one in New England was a randomized trial. So it's a randomized double-blind trial. So that's you can trust that. Second is, if you look at the activity, the inhibition of the antivirals, there's actually no changes in the across all variants, even with XBB1. So I don't think it, there's no evidence that it's really decreasing in efficacy. So I still think molnupiravir will help, especially in elderly, immunosuppressed, and multiple comorbidities. It's less effective. So it depends on the population. If you have a population who is younger, already were infected or vaccinated, of course you won't see much benefit with molnupiravir. So it depends on your population. So the New England Journal of Medicine, the population was immunologically naive, at the time. So most of these patients were a high risk. So yes, so that's probably they've showed the efficacy because of the populations. So No, you can show the efficacy even in this younger population. But you need more patients. So instead of like 500 patients in one arm, you're gonna need 5,000, and that will be very expensive. So so the more patients who are who had infection or vaccination, the less benefit.
What's a good thing about molnupiravir? It's quite inexpensive, relatively inexpensive compared to the other medicines, no? For those who had mild COVID.
Yeah, inexpensive, and it's probably less because there's less interactions. Nirmatrelvir has like interactions with probably at least 300 drugs, but most of them are moderate. Maybe at least 10 that are really almost really contraindications. At least 10, but the good thing is Paxlovid is only given for 5 days. So you can solve it by just stopping. For example, the most common interaction will be with a statin. Okay, if you stop the statin for 5 days, nothing will happen. The patient will not have a heart attack. Stopping the statin for 5 days, you can stop it. It's not a problem.
And yung mga Lipitor, Lipitor.
Yeah, yeah. If they're Lipitor, atorvastatin, stop it for 5 days. Nothing will happen to the patient.
Okay, all right. You also mentioned, Franco, that in the US, it seems like what's going to be the guideline will be at least a yearly booster vaccination, treating it like a flu vaccine, right? Where do you see this in the Philippines? What will be? Do you think this is something that we should adopt?
It could be a problem just like influenza, because for it to work, first it has to match. So we need like probably an AI to forecast the variant that will be dominant in the future. That's gonna be hard. Second, it's the same thing with influenza. Second is COVID has to become seasonal. So because the vaccine, especially for infection, only works for about 3 to 4 months. I mean, for severe, but you still want a vaccine that prevents the infection. So it works well in the first 3 to 4 months. So if it's seasonal and you can time it, so let's say it comes in December to March, then you can give it October, November. So this, and we think that will happen because the common cold coronaviruses are seasonal, at least in the United States. They come in December and then ends in March. So we're thinking that will be the same thing for COVID-19. But in the Philippines, just like influenza, sometimes you have two seasons, right?
Yes.
So, but it's impractical to give 2 vaccines in a year. So that's actually the solution, is to give 2 vaccines in a year, but it's not practical. So the same thing with COVID. So that could be a problem if it doesn't become seasonal. But at least we know there is a protection against severe disease. So that so at least for keep repeating myself, elderly, immunocompromised, multiple comorbidities, that should help.
Can you just, since you keep on harping on the senior citizens, the ones who are immunocompromised, how about in kids? What any new recommendations in kids in the United States or CDC with regards to vaccination or booster, the bivalent one?
Yes, it's controversial because our data is more on 18 years old and above. Okay. We've shown that it actually works for 18 and above. But FDA approved it for 6 years and above. So that's controversial because the mortality rate is much lower in kids. So for example, let's say 80-year-old, the mortality is 10%. The mortality for kids is 1,000 times lower. 1,000 times lower.
Right.
But if a kid dies, you lose what? 70 years of productivity, right? If an 80-year-old dies, they already had a full life, right? They already they already disabled.
Papunta pa lang yung mga bata, pabalik na sila.
So you cannot say, oh, 1,000 times. So you have to put the
Factor
life
it.
expectancy factor too. So
Right.
instead of 10,000, it becomes probably 100 because you have to divide it by 100, let's say. So, but still 100 in terms of life expectancy, it's still much lower. So
Yes.
when you look at the data on life expectancy, there's actually a decrease in 20 and above. Below 20, there's not much decrease in what you call this life expectancy for kids. So yun ang controversy. So for me, kids should have vaccination, maybe at least one booster, but I don't think they need more boosters, especially if we don't have the right what you call this vaccine booster. It has to be updated accurately. So if it's not accurate, what's the point? For kids,
That's right.
Yeah, it's controversial right now. There's like two camps in the United States.
All right.
Dr. Franco, there's a question here and I think it relates to your earlier point na mababa kasi yung uptake ng booster sa elderly population. But what if the senior citizen has already been boosted and then dumating itong bivalent? Would you still recommend that they get that other booster?
Well, ang problema is the imprinting. We call it original antigenic sin or imprinting. There's an interference, antigenic interference. So what happens if you boost too near, it might interfere. The immunity from the original one may interfere with the new one. So that's why the recommendation is still at least 6 months now. Yeah, before we would tell them, 1 month, because at that time everybody's immunologically naive. But now, everyone probably has some, immunity. So 6 months is probably, at least 6 months is probably better. Still wait, because it might interfere.
So again, Franco, just to reiterate your point, at least 6 months might be a good number to remember. Like either you had an infection,
yes,
or you had a booster previously or a vaccine. Maybe 6 months to get another dose.
Yes,
and
6 months.
The reason why we're really pushing for this is, as like what you're saying, being boosted will obviously make you either if you had infected and you become like a hybrid. But a lot of our kababayan meron na yang na-infect na yan eh. So really, magiging hybrid ka. That word hybrid actually in this scenario is quite good, no? Pag sinabi kang hybrid because you seem to be the best protected in terms of severe infection.
Yes.
Based on your... Okay, thank you.
But remember, most of these studies are in younger patients. So it's not like the studies were done in patients who have multiple comorbidities, or especially immunocompromised patients.
Right.
It's usually not included in the studies. There's a big chance that at least 5 to 10% will actually don't have any immunity at all.
All right.
So unless you have a test that will reliably, right now they're trying to, they're looking for it's hard to get it's like hepatitis B. We use 10, right? If it's less than 10, then you need a vaccine. It's more than 10, you don't need it. So we have a correlate of immunity. So we don't have that very specific number yet for COVID, but at least I gave you the studies. It's probably about for severe infection. It's about it also depends on the assay. So if it's live virus, it's probably 15. If it's pseudovirus, it's 1.5. If it's a antibody to the spike, might be 15. So the problem is it might be different for different assays. And second is there's a difference between severe and symptomatic infection, the correlates of infection. So it's still very hard to, unless you're a researcher, probably hard to interpret the numbers. Unless it's 1,000, we check your antibody titer and it's 1,000, sure. That would suffice.
Okay. Meron ka pa ba, Raymond?
I think that would be it. Maybe we could have our fun quiz on the screen so we could answer it. Okay. Can we also have the one on Slido para lang makita po ng ating viewers on the screen? Thank you so much. Okay. So for our first question, so Dr. Franco will answer both questions po, no? This one, it looks like there's more than one correct answer, but the question is, what is the best immunity against COVID-19, Dr. Franco?
Well, if you really look at the data, it would be hybrid immunity. But if you have multiple boosters, especially in the older population, that might be equivalent to hybrid immunity if you had multiple boosters. So for me, those two with booster hybrid immunity.
All right.
Okay. And then for our second question, ano po, what is the best treatment for infection with XBB 1.5?
Well, antivirals, of course. We already know the monoclonal antibody will be useless. And the Zitromax is an antibacterial medication. It will not work against viruses.
Although interesting po, may mga sumagot din po na azithromycin, mukhang yun po yung parang supplementary na binibigay para sa mga nagkakasakit ng kanilang upper
Well,
The
problem is, let's say they come in and sometimes you're not 100%. Before, statistically it would be COVID, but now, at least here in the United States, when they get sick, it can be RSV, flu, or COVID, or sometimes atypical pneumonia. So just to cover everything, they'll give Tamiflu, Paxlovid, and Zitromax. So that's the problem. It's more of an empiric treatment. But if you already know it's Omicron and there's no concomitant infection, of course, don't give azithromycin.
Okay, so I guess maybe now it's time to ask our panel for their brief parting words to our viewers. Let's start with the...
Pero before that, Dr. Jonas will have the evaluation poll muna, so they can give them time, at least a few minutes, to compose their final messages to our audience.
Sige.
So here po, at least for those who are attending in the Zoom, we do not send out a separate evaluation poll. Ito na po iyon. So we encourage everyone to participate in this evaluation poll. It's 5 questions, 4-point Likert scale. First question, panelists demonstrated thorough knowledge of the topic. The panelists were well prepared and organized. Number 3, panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. So we will not be closing this evaluation poll po, as we move on to the final messages from our speakers. Dr. Jonas?
Looking at the poll, parang 95% of the audience really.
Yes, sir.
Very happy, very satisfied with our panelists today. Okay, so let's proceed now with the parting words to our viewers from our esteemed panelists. Let's start with Dr. Saloma, to be followed by Dr. Felizarta.
So, Dr. Raymond, Dr. Jonas, and the team behind Stop COVID Deaths and TVUP, it has been a privilege for me to be part of this webinar series. I think you have appeared here 4 times already, talking about the different kinds of variants circulating in the country. And I would like to thank the team for all your efforts, and of course to our panelists and the excellent presentation of Dr. Felizarta, which which answered a lot of our questions. So we here at the Philippine Genome Center, in partnership with the DOH Epidemiology Bureau and the other laboratories around the country, please feel assured that we are on standby and that we are watching whatever variants are coming into our borders and are circulating in our communities. So at least for that one, you can trust us. For the rest of the 2023, our budget is here, and we will continue, and the learnings that we have with COVID-19 will also help us prepare for monitoring threats in our environment. So thank you very much, and stay safe, everyone.
Dr. Franco, how about you, sir?
So at least in the good news, most of the people in the world right now are either vaccinated and or infected. Majority have hybrid immunity. So this will help transition from epidemic to endemic. But even the endemic COVID will be brutal. From 10 million people dying every year, that's the estimated excess deaths. That's with the lockdown. It's now going down to 2 million every year, without much social distancing or masking. But 2 million is still 5 times higher than influenza. Influenza kills about 400,000 per year. So it's still a brutal endemicity. And the reason for that is most of the deaths will be coming from the immunocompromised, the elderly, and the patients with multiple comorbidities. These are the patients that we have to be very aggressive in regular boosting. So at least hopefully we can have the annual updated vaccines for them that will help them. Thank you.
Go ahead, Dr. Jonas.
Thank you, Dr. Saloma and Dr. FELIZARTA. So now, to give us a synthesis and summary of today's webinar, let me give you again my partner, Dr. Raymond Sarmiento.
Thank you, Dr. Jonas. Mabilis lang naman po, but before I go to the synthesis and closing remarks po, we are seeing that at least 89% of those who participated in our evaluation poll really strongly agree, which is a testament po again to the quality of the presentations given and all of our excellent panel of speakers po. Maraming salamat po. Marami po natutunan. I think this is the although it's our second webinar, it's one of our most attended since a few months ago. Marami po talaga nanonood kapag with regards to any variants, if it's Dr. Franco or Dr. Saloma who's on the panel, they are there. So we really would want to extend our deepest gratitude to them all. So
blockbuster sila. Blockbuster.
Yes, sir. So for our webinar for today, the take-home messages really would be the best protection for XBB 1.5, although it has been regarded as the most transmissible. Really, it's a combination of yung hybrid po, which will be natural immunity and also the vaccination. If you have had multiple boosters, that will also be very, very helpful. Those who are 65 and above, recommended po to get their bivalent vaccines as well. There is value in those bivalent vaccines. So for those who are saying na baka naman hindi siya makakatulong, yes po, makakatulong po siya. And really looking forward, especially for those who are part of the immunocompromised population, those who are part of the vulnerable groups po. We hope that could be made available to them so that they will be better protected as part of our protection po for this one. We have been seeing in the news po that now at least 80% of the population in China ay natamaan na po ng COVID. But really, it should be more about how we protect ourselves, how we are using all of these non-pharmacological interventions to also be in preparation of those that we will be getting as part of our pharmacological interventions and the vaccines as well. Please take note that antivirals po, not really so much the monoclonal antibodies, that's not really recommended na po, nor the antibacterials, nor kung ano man po yung masabi po sa inyo na ivermectin or kung ano man pong other treatment options. Though antivirals po, really molnupiravir, remdesivir, Paxlovid, those really would be very, very effective against COVID-19, including XBB 1.5. And then finally, Kraken po, hindi po talaga siya dapat katakutan, especially since statistically, marami na po sa atin perhaps nagka-COVID, especially those mga nagkabakuna na po. So not really something that people should be very close off about, and really hoping that that's something that we continue to be prepared as well as be protected po. In Dr. Saloma's presentation, take-home message po, and especially since all of the hard work that's being done by the Philippine Genome Center, including the setting up in UP Visayas and UP Mindanao, kasi dati po isa lang po ang ating PGC, no? So very thankful po that something similar in UP Visayas and UP Mindanao has been set up. Is really a testament to the hard work being was one of the pioneers. Dr. Saloma has really been at the forefront of this one. Very, I don't know if we are pleased to hear, but that or dahil or baka naman wala pa siya, parating pa lang si XBB 1.5, but at least ang nasa atin pa po is BQ 1.1 at saka yung 2.75 po, no? Those are the in terms of global prevalence na nandito po sa Pilipinas identified. Wala po dun sa listahan ang XBB 1.5, and hopefully that stays the same, and we continue to extend our gratitude to the Philippine Genome Center for their very hard work for today's, not just for today's webinar and sharing their presentation po, but for the work that they have been doing all across the Philippines. So maraming salamat po, and I'll take this opportunity. Next week po, we have another exciting topic to bring you. Ito naman po ay may kinalaman sa climate action at saka sa health security. So we have an excellent lineup of speakers again who will be joining us, and we hope to be able to have you again. Sana po marami pong mag-attend. Very important po and very timely, as more and more conversations surrounding climate change and how it affects health, especially those who are watching from the Prince Mahidol Awards Conference na mga nandun po. Sana po ay mas marami pa po ang mag-attend for next week's webinar. But before we conclude our program, All Stop COVID Deaths webinars are archived po for viewing at the TVUP YouTube channel for your convenience. Same for our Stop COVID Deaths Shorts. Matatagpuan po ninyo ito sa www.youtube.com/TVUPPH. These are very short and consumable videos, whether you're riding the train, riding the jeep, riding the bus, on the treadmill, o kung ano man po, mapapanood nyo po ito. At kung nagpapaantok, pwede rin nyo po manorin po ito. Very short lang po ito, and hopefully that's something that will be valuable to you with the nuggets of wisdom. Okay? So this formally closes po our webinar for the week, and we look forward again to your company again next Friday. It's a date. Dr. Jonas?
Maraming salamat, partner. Thank you for inviting me. It has been a productive webinar. Yeah, we look forward to see you, everybody, to see you on Friday. So just like what you guys usually say, together we can stop COVID deaths.
Thank you so much, Dr. Jonas. Next week again po from 12 noon to 2 p.m. Friday. So in the meantime po, no, keep safe, keep healthy, and see you online.